This team needs to be trained on this, though I have a little bit of idea because I have heard it
Yeah,
that even if a organ is available and you are at the top of list,
yeah.
does not mean you are going to get that organ because this organ might not be the
Be a
best
good
fit
fit
for
for you.
you.
Yeah.
So what are those technical things that make the organ befitting for a recipient?
So a recipient also has certain characteristics, how hot or cold they are immunologically. So if you are immunologically very active person, your specific antibodies for HLA antibody, class 1, class 2 antigens are very high. And you might be somebody whose immune system is so strong that might reject that organ. You might be the oldest recipient on the list. You might be, in terms of size match and your group match, the best match for the organ. But every organ should go to the recipient where it will work the best. More than in a system like ours, where organ is scarce, I think there are about 10,000 heart lung failure patients in India. About a couple of thousands of them are on some list, with only about 250 transplants taking place in a year. So you can understand only 1 in 8 gets an organ. So you have to make the best utilization of the organ as well as the best for the recipient. In choosing that, you at times need to make a sacrifice in terms of choosing a slightly lesser senior person on the list, maybe a recent registration, but who was immunologically better, who was health wise fitter, who was maybe a little bit of a size mismatch, but an ABO batch transplant. And you offer the organ to that person. In the Western world, in US, Canada, you would have what is called as the LAS or the lung allocation score. In India, unfortunately, we don't have one. But as a team, we do upward of 100 transplants a year, 100 transplants a year. We are trying to formulate a lung elevation score. It is a multi-unit, multi-team concept that we are toying around with. Um, some of our colleagues regularly feature in this international consensus statements and other selection panels, and we've also formulated some white papers or some consensus statements in the country as to how it should be formed. And I believe in the next couple of years, India should have a heart lung allocation scoring system so that that fallacy that exists, or the Duckworth Lewis uh, aspect to it, which people often you know um, use to their I would say, yeah, to their advantage, either for the organ or against the organ. That thing will go. Everything will be black and white. Everything will be in down rules. Everything will be as per the predefined protocols. The lung allocation score in India should be a reality in the next couple of years. We have made a presentation to the National Organ Transplant Body, NOTO, and they have received it very well received it. So I think we might have a.
So from one cadaver lung, how many transplants can be done?
So normally, single lung transplants have fallen out of favor these days, so we do a double lung transplant. So from one pair of lungs, there's normally a single recipient that you get both the lungs.
Because earlier they were actually
Earlier, yes, initially when lung transplant became a reality in the mid 1980s, Curtsy Joel Cooper and his team that they started in a hospital, a lot of single lung transplants happened. It still does happen in the Western world because of COPDs or bronchial asthmas or end stage airway disease getting transplanted, in which case one lung may be distinctly more affected than the other. But in India, where interstitial lung disease, hypersensitivity pneumonitis, connective tissue disorders, SLE, Sjogren syndrome, these are the major recipient population. Doing a double lung transplant is all the more a reasonable biological step.
on the upper side. Is there an age limit of the patient who is seeking an organ on beyond which we should not be attempting or we should not consider him for a transplant?
It's both yes and no. So no, there is no defined legal age limit for a recipient. Somebody as old as 75 or even 80 can take a transplant. In the Western world, anybody above the age of 65 in any public funded system is not offered a transplant because it is believed that if you live 65, so you had a good run at life. In India, we have transplanted people even in their mid 70s and they are doing well for that's what about 7, 8, 9 years now. So somebody that had about 8, 9 years of life reserve in him, let's see an organ transplant, should be given a fair chance. But anybody above the age of 65 is a very, very calibrated decision to offer him or to select him or to enroll and enlist him for transplant. 65 to 70, think twice. Above 70, and only if he's a real, real good candidate with everything else working for him. Though there is nothing to prevent him, but we have a lung transplant selection meeting. In that meeting, we often discuss with the family, and there have been occasions when we have refused families listing for the organ transplant because the patient, apart from heart or lung problem, has other comorbidities which do not make him a good candidate.
Is there a similar limitation in the donor?
So donor, anybody, any adult between the age of 18 and 60 that can potentially raise
So below the 18, for example, a pediatric brain dead cannot be given to other pediatric recipient.
pediatric brain dead can be given to a pediatric recipient, but that has to be approved by a specific hospital approved body. That would have one pediatrician, one independent clinician, and somebody
It's
from
possible.
society. Yeah. So the legalities are much more. For a routine adult donor, it has to be between 18 and 60. Um, Above the age of 60, again, you need a geriatrician to certify that, you discount on the age and you would kind of, because of the fitness of the person involved, because he might be numerically age 62 and he might preserve body function. He's good to donate. You need a geriatric opinion differently. This is what the Organ Transplant Act says. We blanket say no, anybody at any age can donate, but no, if you're above the age of 60, you need a geriatrician kind of certify that, oh yes, you are above the age of 60, you are good for a transplant.
I read it somewhere
Yeah.
that a smoker's lung is a better lung to be transplanted. How true or false this is?
No, not really. So, yes, smokers can donate, but it depends on your pack years. If you are below 20 pack years, you can donate. So, 20 pack years is smoking about 20 cigarettes a day for 20 years in your life. That is 20 pack years.
That's all right to be donated.
Yeah, till that it is all right. Below 10 pack years, you frequently taken lungs. Um, Occasional smokers or social smokers or people that do not or have not been able to numerically quantify their pack years in terms of uh, you know uh,
So
reservation
basically, the
dates.
lung has
The
to
lung,
have some life
yeah,
left
the
to
quality of the
live.
lung has to be good. So anybody below the age of 35 is very unlikely to give you a 20 packet history. So same for about 40, 45. Beyond 40, 40, you can possibly have people that are
Late
that have a
starters.
20-year smoking history. Below 40, you can have if you have very exciting people around. Society is getting exciting, so there is a believe that you can't. Right,
So continuing with some lung questions. So you would also deal in thoracic cancers.
Mhm. I do.
So the lobectomies
Yeah, yeah,
and
lobotomies and wedges and wedge with lymph node clearance with a frozen section on table, uh, which decides whether we proceed or don't proceed or just leave it as is with an arm zero margin. Yeah. And lobectomies have ceased to be the standard treatment for lung cancer. This is another very, very troubled territory. I'm getting myself right from a teenager. I've loved trouble that attracts you, I attract trouble. So if you look at ISSL, if you look at any international body, today the way forward is segmented. Find the tumor, immunofluorescence dye the tumor, identify the tumor, you take 1 centimeter margin around it, you do a segmentectomy, non-anatomical segmentectomy. You send it for frozen section. If they report that the margins are a centimeter clear on either side, you have R0, you've resected all the nodes. Node resection would take about 2, 3, 4 hours. A lobectomy would take about 30 minutes, 40 minutes, 1 hour, 1.5 hours. Done. Lobectomy is an easier job to do. Segmentectomy is a tougher job to do with a lymph node, not sampling. I'm using the word clearance. So lymph node clearance means you have taken all the lymph nodes on that side from 3 different stations as is identified in number from 1 to 15. You have taken 3 different stations, completely cleared them, you send them to the biopsy. They say that less than 1 out of the 3 are negative, then it's a complete lymph node clearance with an R0 resection. Segmentectomy preserves a lot of your lung function with you. That is the way forward. You would be put on a surveillance CT scan program, whether it's a public funded system or a private funded system. You would probably have to turn up for a CT scan every third month for the first year, 6 months for the year after, and then probably yearly. And it has been seen in the Western experience, even as part of some non-cancerous trials that have done low-dose CT scan in people with an LRI principle, radiation as low as reasonably acceptable. They have seen that segmentectomies have had a lot better cognitive functions at 1, 3, 5, even 10 years. So lobectomy today, blanket lobectomy today has fallen out of favor if it is an early diagnosed cancer. For anything, for any stage 1 or stage 2, lobectomy is fallen out of favor. For a stage 4 cancer, where debulking or taking out the entire lung was the option, lung transplant has come back as an option for those kind of lung cancers. End block remove everything and just transplanting the lung. We are having a masterclass in the KIMS Hyderabad, which is kicking off with the Lung Cancer 360, meeting on the 20th of August. I'm supposed to travel that day, which is lung transplant, an option for advanced lung cancers. And that is kind of fashion trend that's coming back in thoracic surgery.
Uh, Two last questions, and you can choose one. You can tell the team uh, about any case where you faced significant amount of challenges, either on the technical side or on the empathetical side, which was personally a challenging case for you, and any message for the team which you think.
Coming back to my trouble attraction when I attract trouble, Aditya will be exposed to that case. So this is a gentleman that has come visit our dentist hospital, thoracic cancer, inoperable, and given a couple of months to live. Um, and so this is December of last year. And I said that if I debulk the tumor, this guy might live a 6 8 months. Tell his family. His family wants him to live any distance. And as somebody who's lost a parent to cancer, I, I, I can relate to that. At some point in your life, you're really pitted against the wall of losing a parent. Any duration is good. Any duration. So, operate this guy. His chest wall is hostile. Open him up. I do an R0. I have R0 resection, total arterial graft. So the right thing done the right way is something that I absolutely love. This guy was given an estimate of 20,000, and I blew up 70 staplers when I reconstructed his chest wall. He's alive, and the proof of the pudding is in eating. So, in 8 months, he's alive within the lab. He's taking chemotherapy. A huge bill pile of over about 12 lakh is added to his bill. Family, some of it, some of it. I propose the industry partners to help with some, consumables as a difficult piece to be done. They have agreed to it, very generous. We operate this gentleman in their life for about 8 months. He's basically giving um, two kids their father back for a year. Probably a couple more years with him, probably the last few months with him. Then makes the difference. And operated from about 2 in the afternoon to 1 a.m. in the night, 11 hours.